If you will, we can go ahead and get started. Yes, you want to We hope everyone is doing well. And we have a very, very exciting session in store this morning to kick off the activities for the third day of the disparities meeting. All right, so while they're getting settled, the title of today's session is Addressing Advocacy at the Bench. And I don't know if you guys had the opportunity to attend any of the scientific sessions over the last couple of days, but there seems to be a common thread that I think the advocates play a very key role in terms of just your experience, in terms of just the capacity that you operate in, and in terms of helping facilitate research and really addressing some of the complexities that scientists encounter on a day-to-day basis, such as how do you employ effective recruitment strategies, or how do you properly engage communities. And so these are just some of the discussions and I think some of the topics that we'll cover this morning. Now, before we jump into this awesome session, I would like to first just recap how I first entered into this organization, the American Association for Cancer Research. In 2006, I was recruited to Moffitt Cancer Center. And, part of the faculty requirements is dissemination of research, right? And so I asked my division chief, who was then Dr. Tom Sellers, so what professional organizations do you recommend that I become a part of? Of course, he said, ACR is the best organization related to cancer research. You should definitely join ACR. So I started going through the process, and you had to have 2 letters of recommendation by full members in order to be accepted into the organization or part of the process. So I went through that, and so I said, okay, now that I'm a member, what do I do first? I said, well, maybe you should sign up for the Scientists Who Survivor program. And then that's when I met Karen. I just want to take just a brief moment just to acknowledge Karen and all of her hard work that she's done. Karen, you stand up in this way. She has done a tremendous effort. I've been involved with this program since early, and I'm just to see it evolve and to grow and to see the cohort of survivors just expand and continue to be engaged, not only at the disparities meeting, but also at the annual meetings, was tremendous. So I want to thank Karen for just an awesome job and just keep on just being great. Okay. All right. So we have an outstanding panel, in store this morning. I'm going to get into it because we only have an hour, and I know you guys want to attend the 9 o'clock plenary as well. Our first speaker is Mary Jackson Scroggins, who's also an MICR council member. Mary Scroggins is a cancer survivor, health advocate, activist, writer, producer, and founding partner in Pinko Hugs and In My Sister's Care. She continually advocates for improving gynecologic cancer awareness and care for medically underserved women and on eliminating health disparities. Now, just a couple of logistics. We have 10 minutes to present. I'm going to be a stickler this morning just because it's going to be a great session. We want to get all the presenters in, and then we want to have a very robust discussion afterwards. So we have 10 minutes to present. And so at this time, I'd like to invite Ms. Mary Jackson Scroggins.
Good morning. The timer shouldn't start until I finish saying my good mornings. Good morning, everyone. You can start the timer. Okay. Let me figure out how to use the little thing first, too. How do you, oh, that works. Okay. Okay. Good morning. I'm just going to speak briefly, and there are lots of slides here, but some of the slides are just here for your reference so that after the, the session, if you like, you have a little bit of information. So I believe that advocates are natural and necessary, I should put equal, partners in research. So that's what I'll talk about. I'm not going to read this tribute. I include it in every presentation I give because it's important to me. But I would like to thank all of you. I'd like to thank every advocate in the room for your significant presence at this conference and in all the sessions, and especially for your statements during the opening session. You were educated, inspired, and you were examples of what research advocacy is. So thank you very much. And this is just a tree that grows somewhere in Kenya that's dedicated to all of you. And my purpose here is just to enhance your understanding of research advocacy and advocate research partnerships. And I'll talk a little bit about why advocates, why patients become involved and how they prepare and how there's a bi-directional education and so on. And then the types of opportunities that are available. And I'll key in on one of those opportunities as an illustration and a little bit about the impact that Jim Williams will talk about impact, so I'll say very little about that. So just starting so that we're all on the same page. Research, and I have research in advocacy and I have research in the Friends because I never thought of myself as a research advocate. I just think of myself as an advocate, but people tell me I'm a research one, so I'm going to go with it. Research advocacy is and is not. It's a partnership. It's a true partnership between the advocates and the researchers. It's natural. It should happen. It should always be the case. We all have complementary skills. We have the same goals and various complementary skills. It's necessary. It's not a do it if you can and if you have the time. It's necessary. So we should think of it that way. It's not easy. It's not for anyone who is dissuaded easily, who becomes discouraged easily. It's not short term. You have to invest in this. And it's not free of cost. I'm going to talk about that just in a minute. I won't get stuck on it, but I got to think about the free of cost thing. What research advocacy requires? It requires a dedicated force of volunteers, but I want to be clear about this volunteer thing. Volunteer does not necessarily become synonymous with uncompensated. Advocates should be compensated because they provide so much and put so much into the enterprise, but I won't get into that now because that'll be more than 10 minutes. So you need a supportive advocacy network and a research system that wants you there and understands what your value is. You need to have genuine, you will develop, you won't start with it, but you develop genuine respect and acceptance. And there's training, but just keep in mind that the training is bi-directional. We're not the only ones learning. People are learning a lot from us, and it requires a huge commitment. Why people become advocates, I've got all of this stuff here, and all of you know these reasons and more, but the central reason is that we want to give voice to all advocates, and emphasis is on the word all. And if we do do the things that we come here to do and that we mean to do well, it will result in trials that are more focused on issues important to patients and advocates, that's more patient-friendly, and that will accrue. And we can do a lot in terms of this accrual piece. And I don't mean in terms of accruing, but making sure that people understand when trials won't accrue so they won't move forward and waste our time and money and human resources. So, how do you prepare? You prepare in all of these ways. They're all very straightforward. You're participatory. You become educated. You're not trying to become a scientist, but you're trying to be the best advocate that you can be. You learn the language and so on. You network. And you get a mentor, or more importantly, maybe mentors. Find people that will mentor you and do it well. Basic rules, and for me the first rule of patient advocate participation is come prepared or stay home. And when I say stay home, I don't mean literally you can't be here, but you can't be actively in this thing. Find another thing to do that will be important and helpful. But coming unprepared is worse than not being present at all. Okay. So a few things that I'm just going to tell you, just share about research advocacy and about advocates in general. One of the things that we have to understand is patient protection and ethical research ethics. And the protection part of it are all those mechanisms and regulations that are in place to protect us. And the ethics part of it is making sure that you apply them. So here are some of the criteria that we must understand. Please don't take the time to copy this. I assume that you'll have copies if you want it. I want you to. This is for your information. In 10 minutes, I can't share all of it. You need to understand the NIH policy. And the important policy issue here is that all of these grants that have human subjects, and I put quotes whenever I say subjects because I hate the word, human participants are required. It's not a maybe if you want to do it today. They are required to have minorities in both genders because we want this research to be meaningful to all of us. But we have to do our part. You have this little parenthetical down here about the strong gateway link. Strong link to personalized medicine is a little bit off topic, but the fact is we have to become involved in research if we want to benefit from personalized medicine. Just keep that in mind. Informed consent, we can explain to people that informed consent is more than a document. It is a document and a process, and that's an important issue. And often patient advocates are really essential in that. Here are all the lists of things that are included. We're not going to talk about it. It's for reference. And so here's the things that are included in that document part of it. The process part of it is what you need to insist that all of us have. Any participant any person who is a potential participant, that they're not rushed into the process, that they're not rushed into signing. It's voluntary and they need to have the time for that. And so this is the process part of it. So here again, it's for your reference. And here are just a few tips and some other stuff. Clearly I didn't know what to call it. The second rule is, guess what? Stay home if you can't come prepared. I should have said it first. It's come prepared or stay home. That for me is subliminal message number 52. Okay? You either come prepared and stay home, so we have to do the work. And by being here at this meeting, you're preparing. This is a part of your preparation. So communication tips and some other little things. Focus on the collective. We didn't come to talk about ourselves and our own stories, no matter how telling and wonderful they are. It's wonderful how you packaged your statements for the opening session. They were short and succinct, and they served the purpose. So the only time we share our personal stories is to illustrate a point, and so that the collective can benefit. Don't preface your statements with "I'm not a scientist." They know we're not scientists. That's okay. We have our own area of expertise, which is equally important. You can use humor. Humor only if you're funny. If you're not, that's okay. That's okay. It's okay. Leave it to somebody who is and keep it moving. Okay? Be serious without taking yourself too seriously. Don't become overwhelmed and you're sitting there and you almost look like you want to growl. You're there for a reason. People understand it and they know you're serious. Speak confidently because you are an equal at the table. You have to learn the language. No one should have to explain to you what metastatic is. They shouldn't have to dumb down the wording for you. They explain the processes that you don't understand. Assume good intentions. For example, if someone says patients fail, it drives me crazy. Be nice, sit there for a moment, don't let smoke come out of your ears, and you don't get that upset. But you then, very politely, simply say, and you don't even have to say it to the individual because you're trying to educate the room, you simply say that, patients actually don't fail therapies. Therapies fail them. And you keep it moving. Never feel compelled to speak. Just because you're at the table and you are the advocate, don't feel that you have to get up and say something that is meaningless or doesn't add to the conversation, the education process. On the other side, don't ever be afraid to speak. Nothing. When people say there is no dumb question, there probably is one, but you're not going to ask it. And if you think somebody's going to answer it politely. Okay, sit by someone that you feel comfortable with who you think might answer your questions. At the very first scientific meeting I ever went to, I sat by Dr. Ronnie Alvarez, and to this day, I must have had a dazed look on my face when he answered a question, and to this day when I have questions, I contact him 22 years later. So make sure you do that. I've got 2 minutes, okay. This is going to take me 3, and I'm not going to leave until I'm over. Do not become the angry person sitting in the corner. Do not become that angry man or woman because you're scowling because you want people to know how serious you are. This is where I'm going to give an example of something. These are just samples, and it almost runs off the page. I have little dots to let you know that I could have kept writing opportunities. There are all kinds of opportunities. New ones come up every day. The one I'm going to talk about is the Department of Defense research programs. I sat on the very first, as an advocate on the very first program for ovarian cancer research. They had never had advocates before. They'd never had the program. There were three survivors sitting there. We sat there for 3, and I was woefully unprepared, and I cringe when I think of what I probably said that was not appropriate. But anyway, there were 3 of us sitting there. At the end of this 2.5-day meeting, one of the doctors walked up to us and said, "And what is your connection? We're all survivors. What is your connection to ovarian cancer?" We sort of looked at each other thinking that he knew, and we said, "We're survivors." And he said, "Oh, but you look too good." This was not a Me Too moment. He didn't congratulate us. He meant we looked too healthy and too well. He thought of us in a different way. So we educated just by being there. Fast forward 22 years, I'm now sitting on a research team. We're actually a part of a team. There are 10 advocates who are part of a team for a program to see. We're trying to figure out what the characteristics are for long-term ovarian cancer survivors, those of us who really survived long-term, such as myself, 22 years. And we're trying to find out about that. But we are part of the research team. We can veto anything that we think is inappropriate, is written into the document, into the contract. And this particular mechanism came out of advocates who decided at DOD that's what they wanted. So that's just an example of how far we've moved and how important things are. Everything else that I have in my presentation, if I have to sit down, I can without too much, I'm not going to hold on to the podium and tell you about it. As research advocates, these are some of the questions we ask. I'm not going to go through them. They're here for your reference. These are some of the examples. The summary is all the things that I've already talked about, basically, that this is an investment, that we are a part of the system, that it's important that we're there, there's ongoing training, and we have to have a commitment. But we have authentic voices and unique perspectives that nobody else has, and this is a real opportunity to serve. And in closing, this is a statement from a researcher who says, "The presence," and the consumers here, they mean advocates, "at the table is just a continuous reminder of why they're there and the importance of it, and we truly are natural and necessary partners." And I just believe that, I always include this because I believe that nothing is beyond the reach of a group of dedicated, passionate people anywhere and under any circumstance on the planet. If these women in Kenya could do what they were doing in terms of HIV/AIDS, we can do this. We've got this. And I always include my little advocates in training. I might go back to them for a second because I got 2 seconds and I'm about to leave because I see them getting up. I'm getting frightened. And thank you.
Thanks so much, Mary. It's just going to keep getting better and better. This is awesome. So our next speaker is Dr. Flacky Odedno. She will be speaking from the topic, the need for global research advocacy to eliminate prostate cancer disparities. Dr. Odedno works on community-based intervention programs in minority and underserved communities. She has directed more than 20 research projects across the world. Her initiatives include the Men's Health Initiative and the Black Men's Health Consortium in Florida. Please help me in welcoming Dr. Odedno.
Thank you. I'm not used to staying behind the podium, but I've raised a husband and 3 children so I can yell. So you should be able to hear me, right? I'll try as much as possible to stay behind the podium. I have been all over the world presenting with my very good friend Dicey, and we are actually heading to Nigeria in a couple of days, not a couple of days, tomorrow, for 2 more sections. So we pretty much, it's gone to the question section. Hey, you don't even want me to speak now? But I'm going to go back. I don't know whether that's me or not. But, when I thought about this, and believe me, I started thinking about, what I was going to present this morning. And changing. I already had an idea, but then I changed it. And I thought to myself, I think it's very important, when I think about it, I think, maybe you want to hear what, why, how, when. But I want to switch gear a little bit because I think I want to talk a little bit more about the science of advocacy, right? It's great to be advocates. It's great to be working with scientists. It's great to do all of these things, and I'm sure we can cover it and we'll do a little bit. But what about you putting the science of advocacy out there, right? That is what you need to be doing, right? And that's what I want to talk about. So I'm going to start with, why am I here? I owe a patient my career, and I don't even know him. In 2005, I had a Department of Defense grant that required that we do a town hall on prostate cancer research. And we did a town hall. We had all these experts, 6 of us who were sitting in front. I was one of the experts. And one of the men got up and said, I'm 36-year-old. I had prostate cancer. I was diagnosed with prostate cancer. I have multiple friends who are from Africa. I've never had anybody talk about the fact that they have prostate cancer. Is it that when we Black men, because we are here in the United States, that we have prostate cancer? If we go back to Africa, does that mean we won't have prostate cancer? And everybody laughed. And he said, this is not a joke. I'm being serious. And we looked at all the experts, including me, and no one could answer the question. In 2005, we had not started researching the within-group differences among Blacks. We kept comparing Black and white, orange and apple. But Black is not just one Black. Black is homogeneous. And nobody knew an answer about who gets it more. US Black, Caribbean Black, or African Blacks. Because that is the true need of finding the answer to prostate cancer. Because if we know that all these people are genetically connected, especially the ones who overlay the transatlantic slave trade, because they come from the same unit. So if the Caribbean people are not getting it as much as the US people, then we begin to tease out the environmental and biological basis. 2005, we did not have an answer. I told him, I said, we don't have an answer. Because the best thing about being an expert is to admit when you don't have an answer and don't bullshit people, right? I'm not going to say that. I'm cleaning up my language, small by small. So I said, you know what? We don't have an answer for you, but I'm going to take a pause. I'm going to take sabbatical, and I'm going to go to Africa, and I'm going to go and try to find the answer for you. And he laughed. He thought I was joking. I was not. I did take a sabbatical. I did go on Fulbright. Fast forward, almost over 20 years later, multi-million dollars of grant funding later, we are finding the answer. So I want to start by saying that you matter. You matter to science.
We don't know what the heck we are doing. We are thinking in our brain of what we want to find out. But you are living the disease, and you know what is important, and you know the right questions. So I always say to my scientist colleagues, you don't know what you are missing. Because they ask, why are you so successful in getting grants? Because I work with patients. Because I work with advocates. Because I ask meaningful questions. Because I ask innovative questions. You sitting in your lab, you sitting in your population, and you think you know all the answers, and you have never had cancer? What the heck? You don't know nothing. Right? So you matter and you important. So now I want to start with that. And then I'm going to flip. I love the slides because there are different areas of advocacy, right? But the research one is so important. I'm not saying any other one is less important, but the research one is so important. Like I said, we scientists, we don't know what the heck we're doing. We need you. And what we do, and I'm going to kind of circle back. I want to start with the idea. I just talked to you about how I started my research. Fast forward to this time, I have a consortium that is called the Prostate Cancer Transatlantic Consortium that is comprised of cancer scientists, clinicians, survivors, and advocates. We are so proud of survivors and advocates who are members of our consortium. And this consortium has sites in all the countries that are connected by the transatlantic slave trade. Very purposefully, because we only want to study blacks who are connected genetically, right? And this is what we do, it's NCI approved. So one of the goals, and that's one of the things that I always say, it's okay, you know, as a scientist to be doing your work, but what are you doing to be able to ensure that you have equal partners like Dicey that you are working with? What are you doing, right? So one of our goals, we have very specific goal for my consortium, is to increase the power for cancer advocacy, is to be able to strengthen the network of cancer advocates all over the world, is to foster partnership between advocates and scientists. That's what we do. I want to talk to you about the case study of where it is most difficult. Because I could talk about the work that we do in the United States. We've been doing it for over 25 years. And we're great. That's one of my partners. Vange Simmons is a partner. West Schultz. We have a lot. Jim West, Meriwether. We have a lot of people that we work with. But I want to focus on where it was most difficult because I want to tell you that it can be done. And I also want to emphasize to you, don't let's just sit in the country that we have and not reach out to a network and develop a global network. That is how we are strong if we reach out to the world. So what did we start with? We started with a SWOT analysis. We wanted to know the strength, the weaknesses, the opportunities for advocacy in that particular country. Just like you might be starting in your community. Even if you are a patient or an advocate, you don't know it all. Start by saying where I am. What are the strengths, what are the opportunities, what are the weaknesses? And what did we do? Then we started putting together a conference. This is what is called the science of advocacy. It is great that you are part of AACR. I love it. But why can't you have your own conference? It's true. There is a science behind advocacy. And we are not going to do it for you. You know the science. And you need to work on the science. So we started with that. Dicey started with me from the beginning. From the, I can't even remember, 2009. She was one of the faculty. Morocco, South Africa, I forgot. Somewhere in the world. South Africa. And we wanted to train people. So we put a conference together and we started training people. We started looking at how do we foster collaboration. We've got advocates in the United States. We matched them with advocates in Africa to develop mentorship together. Right? We wanted the cancer advocates to be able to do all these things. Empower them. Share ideas. Connect with leading African and international scientists and advocates. Network with leading cancer clinicians. You are equal partners. Network with them. You are equal partners. Discover the world of advocacy. It's the world. Learn about innovative advocacy programs. Join the global war against cancer. Look, let me tell you, as an advocate here, let me focus on blacks because I deal with that. It could be with Latinos, it could be with anybody. If you say you're dealing with blacks as an advocate for prostate cancer, you are going to meet an African man that you need to talk with. You are going to meet a Caribbean man that you need. Are you ready to be able to do that? Are you ready to empower them? The black community is so diverse and we have to work together. If you are Latino, are you ready to work with Puerto Rican? Are you ready to work with Mexican? So you really need to develop develop that world, right? Then we form the consortium. It's not only scientists that are allowed to conform consortium. It's the science. Let's move forward. The science of advocacy. Then we form the consortium. And they are called the ALT, African Cancer Advocate Consortium. And they are led by cancer advocates. That's what they want. Then we did what? We did a toolkit. Because we have to empower people. If you want to become an advocate today, I have 2 more minutes, I'm going to start. If you want to become an advocate today, where is the toolkit to help that person? The toolkit that we now developed as part of the U54 grant that we just got, we are now translating it to Spanish so that toolkit could be used in the Latino community. Right? We did a toolkit, right? We did a survey, that's good. We did publications. Why are you publishing your work? We did this is the science. These are the things that we published. Dicey was one of the authors on leading. What is the science that is coming out of advocacy? We can't just be coming every year and talk. There are millions of advocates in the whole world. Till today, after we published it, I still get people reaching out to me to give them copies of what we published. More science needs to come out. Don't lean on scientists. More science needs to be coming out of advocates. We did a book chapter published by the World Health Organization. There is a science to advocacy. There's not only science to science. Okay? We did a book chapter and we continue. Every conference that we have, there are advocates right at that conference. Mingling, networking, reading, but they also have their own section. Dicey is leading the section. We have 2 conferences coming up in Nigeria. One is on prostate cancer, the other one is on clinical trials. For the first time, we are having a global congress on oncology clinical trials in Blacks. There are advocate sections that she's leading at both conferences because they need to be able to start developing team. Okay? But I want to say, it is nice. Let me just say, it is great to be working with us. We love you, we want you as partner. But as one of my very close friend, Angela Adams, that I've been working with for almost 30 years, said to me, we can't keep working through you. We need to work independently. You can't have it both ways. I agree. If you want to have it independently, have your own science of advocacy. And I'm going to end it.
Next, we're going to have the Colonel, James Williams. He'll be speaking from the topic Patient Advocate Impact in Cancer Research. Mr. Williams is a cancer survivor and has been an active advocate for more than 27 years. He is a principal of Jim Williams and Associates that specializes in prostate cancer awareness, education, and advocacy. Please help me welcome Colonel James Williams.
Good morning. Well, that's 2 presentations where I was saying, I can hardly wait to hear what I'm going to say. It's going to be very disjointed because it's just a couple of points I want to make to tell the other side of the story. As I look around the room, I see a lot of women. I deal with very few men. With my male advocates, please stand. This is a completely different synergy dealing with men. In the military, we have combat troops, and then we have what we call the recon troops. The recon troops are the people who look and go out and find out what's going on in the environment. What's the environment that we have to fight in? And so there's very, 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 very many stages of advocacy. And I wanted to discuss this morning what Mary said I couldn't tell my story, so I didn't.
Fake news.
At the presentation yesterday, somebody asked me about how much did I know about prostate cancer before I was diagnosed. And that's really my story, because I knew nothing about prostate cancer. I didn't even know there was such a thing called prostate. I didn't know where the prostate was, and that was 1991. Do you think that's changed among the male population in 2018? We got a long way to go. So we men, while you women are really into the research and doing all that good work, a lot of us are still trying to do fundamental things like getting men to take better care of their bodies as they do their cause. Women are from Venus and men from Mars, and so when we market all this stuff, we have to package it differently when we're talking to men than we do when we talk to women. For instance, you know, support groups, and they're great, but men don't resonate well with that. My most receptive audience for cancer and healthcare and advocacy are women, not men. And so we have programs trying to get men who have been diagnosed with cancer to come out of the closet and talk to them. Because they, as the previous speakers talked about, they have lived cancer. They are quite reactive to what's going on in their community. And the audience, the target market, respects what they have to say. And it's hard to get those men to come out and speak. And so we have things like posters like this, trying to get men to come out and tell their story. Because when we go one-on-one and talk about, we need you to go into a clinical trial, they have no idea what we're talking about. They don't know what a clinical trial is. Nobody's ever talked to them about a clinical trial. And if you have some experience and been trained in this area, you're very effective. It's very, very labor intensive, and you know that, dealing with the public. But it's very effective when we have men who've gone through that journey and speak out about it. So, you know, we say advocacy is the key. And what's the problem is, and I keep preaching this about, you know, our fee-for-service system doesn't really support what I try to do every day. The health professionals come out of medical school, their PhD programs, and, you know, it's all about diagnosis and treatment. That's how you get paid. We're talking about prevention. We're talking about good health. We're talking about diet. And there's a lot of slick brochures, but the real money at the end of the day goes to hard science. And we need hard science. There's no doubt about it. But the general public, we need to put a lot more emphasis on prevention. We know that will save money in the end. But the insurance executives, and I have a good friend with Blue Cross, he's medical director, and we were in Germany together back in the 60s. And we were drinking one night, and I said, you know, why is it when we come and talk to you about prevention, you give us a lot of lip service. We don't get much reaction from that. He says, you know, here's the problem. He says, you know, it's not a good return on that investment. And when I came out of the military, I went into human resources. He said, you should know this because every 6 months you guys are trying to change your vendor to get a lower premium. The money we put in prevention now, we don't see the 4 or 5 years down the pike, especially prostate cancer awareness. And by that time, you've changed vendors 3 times. So that's the kind of problems that we're fighting. This is what we should be, you know. The health industry should be, the people who work in it should have incentives to keep people well, not just to treat them. Now we pay them to treat. If you're 40 years old, we won't spend a lot of money on you to keep you well. If you're 69 years old, we'll put every instrument we can find in your body because Medicare is going to pay for it. We'll pay for a lot of it. Because it's diagnosis and treatment. That's what drives the system. And that's no criticism on the people who are working in the industry. We as laymen are going to have to change the system. We point at the doctors and physicians and the hospitals and the insurance companies and the pharmaceuticals, but we as laymen are going to have to change the system or we're going to go bankrupt. Do we know what the true cost of care is? I was on a panel, we were checking about the cost of a fish diagram on clinical trials. Have you ever seen that? And it starts here, and we've got some engineers from, I think it was Michigan, and it ran all around the room from the time a trial was initiated to 15 years later, 1.2 billion years on finishing. And he said, you know, if this was a business tool we couldn't do, we would fail. How many of you have been on IRBs? And in the early stage, if you changed the period, you had to send it back. Is that right? If you changed the letter, you had to send it back.
Yes.
We have to do better than that. And I think it's going to be our laymen and the people who sit on these things say, wait a minute. Mary talked about, how much time I have? Thank you, I'm telling war stories. Mary talked about informed consent. And she can remember when we started looking at informed consent, who understood those things? Huh? But the lawyers insisted because of liability that it be 42 pages to protect their customer. And so then we started insisting, saying, you need to put a layman's paragraph in there. So the layman understands what's going on. We ask all this from the patient to come in clinical trials. When do we ever say, well, this is what we're going to give back to you? Many times, we never give them a response on what their participation in the clinical trials did. Sometimes we say, can you give them a free parking ticket? How about lunch? A bus pass, something. Simple things. You people bring that to the discussion. It's so very, very important. And so many times advocates will say, well, I'm not a scientist. I can't contribute to this, but you can. You bring practical and common sense to the table. I think, I'll tell this one more story. Maybe you're going forward. Did I tell this yesterday about keeping in balance?
No.
My second tour in Vietnam, I was an advisor, and my counterpart said one day that he fired his doctor. And I said, why? He said, because I got sick. Because in Eastern medicine, you go to the doctor to stay well. You don't go to the doctor to be sick. It's a yin-yang, it's staying in balance. It's mind, body, and spirit, which all you understand. That's not Western medicine. By the time men go to the doctor, they're sick. They're very sick. And the best we can do is make them unsick. But that's not what we're talking about. We're talking about the full life and quality of life, body, mind, and spirit. And this is what we have to preach, and you do preach it. But that's how we're going to get where we need to go. See, problem with men. How you doing? How's your prostate? Okay. Oh, I'm doing fine. No, they're not. They're leaking, they're bleeding, they're impotent, they're incontinent. Their quality of life stinks at a time when they're retired, and they should get a return on investment. And nobody talks about it. So these are the type of things that we advocates bring to the table. You do a tremendous job. This forum is an excellent opportunity for you to learn, to network, and go back into your communities. Don't be shy about what you say and what you do. Your mere presence is so very, very important. Thank you.
Excellent. And lastly, before we go into our discussion, we have Dr. Betty Thompson, who will be speaking from the topic of empowerment and advocacy, experiences from the community. Dr. Thompson's research is designed to understand why these disparities exist, to help determine the precursors, as well as build the capacity of community-based researchers. Her projects work with local community advisory boards to guide and lead the activities to reduce health disparities of cancer and diabetes. Please welcome Dr. Betty Thompson.
Thank you so much. Good morning, all. It's such a pleasure to be here. And I'm going to talk a little bit different topic, and that I'm going to be talking about how we get advocates and other important people in the community, who are all of you and all of the people in the community, how we are able to work with people to make a change in the rest of the community. And let's see, here's the clicker. And the typical no disclosure slide. I want to talk a little bit about empowerment. When we think about connecting advocacy to research, we think about empowering people in the community. And to understand empowerment, you have to start with concepts of power. And power is usually an unequal relationship between people. And when it comes to cancer and cancer survivors, the power is often in the hands of the people who are doing the treating and so forth. And the people who are the survivors are kind of sitting there saying, okay, I'm willing to do whatever it is that you want me to do. Empowerment seeks to balance that relationship, to try to make it clear that everybody is concerned about the power in talking about a relationship, making decisions, and so forth. When it comes to advocacy, what I think you all are really good at is changing individuals in the community by giving them the tools to be involved in cancer prevention, screening, and treatment. So how do we do this? Well, I've been very privileged to work with a group of people a group of advocates who actually practice this empowerment process. And it is a process. It begins by mapping or understanding the community. And then you have to identify some potential agents of empowerment, many of whom are in this room. And then it's important to consider the social determinants of health. You cannot go along and tell people, oh, you have to, pull yourself up by your own bootstraps. Instead, it's more like, what is it that you need in order to make a difference to your life? And then finally, once we change those norms or those attitudes, knowledge, and beliefs and behavior, we can sustain the empowerment in the community. So I want to talk about a project that we have done in the community. We have a long-term history of providing small grants to people in our community, many of whom are advocates who are seeking to make a difference when it comes to teaching their communities about cancer and empowerment. And so what we do is we run a 2-day workshop where we teach advocates and other community members how to develop a small grant proposal. Then we give these proposals, it's a competitive process, but we give proposals to 2 or 3 of the best applications that we get in our, after our 2-day workshop. In the past 5 years, we've funded a total of 15 of these small grants. And I want to talk about one of them that we have granted. And these have led to increases in advocacy as well as distinct advances in research. So it's not only that you have to know about research the way our other panelists have talked about, but they actually became involved in the research process itself. So actually doing a project to make a difference. So the project I want to talk about is a project called Community Empowerment Partner, Peer Education Approach. And the 2 people who have been instrumental, who are both advocates and in the community, are Bridget Hempstead and Cynthia Green. And they have worked very closely with me as well as others at the Fred Hutch to enhance community empowerment. So they have what I consider a very distinctive idea, and yet something that I'm sure will resonate with all of you. They said that what we need to do to increase knowledge about breast cancer in this case, and to motivate African American women to talk to their social networks about breast cancer screening, we will take an advocacy approach and an empowerment approach that will train trainers to go out into the community and talk to people about the importance of breast cancer research, or breast cancer screening, excuse me. So you see there on the right of your screen the basic design that they used. They decided that they would start with some people who would become trained to be trainers. They would then have those trained people go out into the community and conduct workshops on breast cancer screening. And then they would look at changes in knowledge as well as changes in social engagement to see if it made a difference. So here they were not only just going out and doing things, but they were actually measuring what they were doing. So it was a wonderful way to be involved in the actual research process itself. So the first thing we did was Bridget and Cynthia recruited 14 African American women to be peer educators. And these were called Community Empowerment Partners, or SEPs as we call them. And the SEPs participated in a one-day Train the Trainer workshop that was held at the Fred Hutch that started at 8 o'clock in the morning on a Saturday morning, not so different from this session, and lasted the entire day. We fed them, we trained them, we gave them toolkits so that they could go out and train others in the community. Once those 14 people were trained, they were instructed to each train to try to train another 10 African American women each around breast cancer and breast cancer screening. And then within 6 months, a total of 121 community partners were trained. So starting with this train-the-trainer approach of 14 people, we had over 100 women trained within 6 months within the community. And I wanted to show you a little bit about what these characteristics of the participants were. And you see both the column for the community empowerment partners and then the African American workshop participants. So 94 of the 121 participants were African American, others were of different ethnic groups. And you can see that for our SEPs, our advocates, that most of them were older as opposed to younger. Most of them had private health insurance. They had had lifetime breast cancer screening, although not all of them had. They talked to others about breast cancer screening at the pre-test, and 8 of them, 57%, had a previous breast cancer diagnosis. If you look at the workshop participants who participated afterwards, the 94 African American women, you can see that some of them were younger. Many of them were of relatively low education. Few of them had private health insurance. Few of them, or only 77%, had had lifetime breast cancer screening. And not so many of them talked to others about breast cancer. And only a handful had a previous breast cancer diagnosis. So what happened after all of this? Well, there's something that I think is quite amazing. The first thing, not so surprising, and let's see, I thought I might have a pointer here, but let me show you here. The SEPs, the Community Empowerment Partners, not so surprisingly, greatly increased their knowledge of breast cancer screening. But when you look at the workshop participants, that is the second level, you can see that they also greatly increased their breast cancer screening, showing that advocates can go out and make a real difference. And then in terms of communication to others, to their social network, they also had big changes in there and tried very hard to express their intention to talk to others about breast cancer research. Not so surprisingly, Bridget and Cynthia had a publication that arose from this particular activity, and that was wonderful for them. And what did we learn? We learned that it was possible to recruit, train, and enable African American women to serve as peer educators, that both groups increased their knowledge of breast cancer screening, and they also agreed to talk to others about breast cancer screening. So in conclusion, from our research, we learned that knowledge is empowering, that empowerment is clearly linked to advocacy, And linking research to advocacy is not only possible, but benefits both the advocates, the researchers, and the community. And then lastly, working with advocates is fun. And kids are fun being important advocates. And I'd like to end at this point, okay? Thank you very much.
Can we give our panel another round of applause, please? And so in the next 10 minutes, because I know the plenary starts at 9 a.m. and a lot of you may want to attend that as well, so definitely want to have that as an option. But I thought, over the next 10 minutes, we'll have a discussion about some of the things that we've heard. I also want to, I know a lot of publications are cited among the speakers. I also want to bring the attention to the audience of a recent publication within one of the ACR journals entitled Promoting Scientists Advocate Collaborations in Cancer Research. Why and how. This article was published in the Journal of Cancer Research online on August 17th, 2018. I think it's now made available as of October 15th, 2018. And again, another framework and model and example of how advocacy works. So now we'll open it up for questions for our panelists. Questions. Everybody's burning with questions.
Okay, good morning.
Right here. Yeah, then we have another. Start with this one.
Morning, everybody.
Good morning.
Thank you very much for the presentations. Really learned a lot from them. For both the prostate cancer and the care educators, I just wanted to know, in terms of rolling out the programs, are your educators supported? Are they paid? And or is there any kind of reimbursement for them? How do you sustain them doing their work?
That's a great question. So for us, there are two levels of collaborations that we have. For the health educators and the outreach workers, yes, they are paid. They're paid through. So, for example, for me, one of the things that I do, I have people who are prostate cancer advocates who are patients who have been working with me, and I have the flexibility within my institution to use what we know as residual money that I'm bringing as I wish. So for those who work with us, I put them on as OPS, and they get paid when they work with me. And then there's another level of individuality partnership. So for example, my partnership with Dicey, we don't have any funding for honorarium, but I make sure that the travels and everything that needs to be covered is covered. And that's the struggle. I mean, I have to let you know. For scientists, majority of the grants that we get is not allowing for that. And when it allows for honorarium, the honorarium is so minimal. So we put them on for honorarium, but the maximum you can get is like $1,000 honorarium. Yeah, but they do much more than that. And so you have to somehow, leverage other things. If there's opportunity for you to sponsor their travels, sponsor their travels. If they call on you to come and talk, like Dicey calling on me that, I want you to do this. Yes, I'm there. And you don't need to do anything. I'm there. So that is kind of multiple ways to do it. But I know for a fact that I do have colleagues who don't have the flexibility that I have, that have a little bit of funding that I can play around with and use it to be able to pay them, and that becomes a little bit difficult. So that's one of the challenges that they have. Yeah, I'm not sure. But for the former ones who are on the project that we're doing, yes, they are paid and they are part of our team.
Good. Excellent. I think we have a question right here, and then we have one in the back as well.
Okay, good morning.
Good morning.
Thank you so much for each of your presentations. It was just so insightful. Learned so much. My question, I'm really interested in research advocacy. I'm an independent advocate. So my question is, how do you work with that where sometimes certain boards, certain organizations want you to be affiliated with want you to be affiliated with ACCR or something, and that's not necessarily my space. So how do you work with that and still keep some level of autonomy?
I'm sure I'm going to speak up. Okay, I think that's a really important question. It's one of the things that I almost always always make sure it's included in some way in anything that I work with. That in fact we want people who authentically are from the community and work in the community, and often we don't get in these positions because we're not affiliated with a large organization. All you need to do, number one, is make sure that you do in fact become aware of these opportunities, and then indicate your connection in your community, because you have to have some connection, because we want these things to be shared. And that's one of the things. I think the downside of the requirement is that, indeed, we don't belong to the large organizations. We often have small organizations in our community that we're involved in, and they don't have to be healthcare. So don't think that you have to have a healthcare involvement. And anyone who's a scientist in the room and who works with advocates needs to make sure that they build into their process the understanding and the acknowledgement that if we want to have a diverse workforce in terms of advocacy, we're going to have to step outside of what's considered mainstream.
Just one quick follow-up, please. So then it doesn't, you can get, like, when you're asking for like letters of recommendation, it can come from anywhere.
I belong to something in Washington, D.C. that's called the ANC, and they are advisory neighborhood councils or something. I probably got it wrong, but anyway, it's ANC. I can get a letter from my ANC president saying I'm active in the community and work on the education board or whatever.
Dr. Thompson, did you want to respond? And then Dr.
Okay. So that is a really good question. The first thing I would suggest is if there's a cancer research center in your community, go and find out what you can do with them, because most cancer centers nowadays have to have an outreach and engagement core. And they're always looking for advocates to join them, and they would be happy to write letters of support and so forth. Otherwise, there are volunteer organizations such as the American Cancer Society and other organizations that are always looking for advocates. So you have to reach out to them and tell them, hey, I'm here, and I would like to help you. And you can, in turn, write me a letter of support and so forth.
Yeah, I wanted to say there's really there's strength in power. I understand your maybe I'm coming from this in another way. It's the same thing when I encourage and when I mentor young scientists. Even with me as a seasoned scientist that I've been for a long time, you have to be part of the network and the consortium. It doesn't have anything it still does not really take away from your independence. I would strongly suggest, because I've seen this, I've worked in this area for almost 30 years, and if you are not well connected within a network, within a consortium, you are not going to be successful. And this is one of the reasons why in very low resource countries that I work with globally, I encourage that even if there's no consortium, you form one. You are not saying people are essentially, going to follow this rules. It just says that we have this network, and there's power in that network. The independency is great, but this line of work that we do requires we lean on each other. I'm just telling you. You cannot do any research or help patients without the sharing of the information, without leaning on each other. This is what I say to the people that I mentor. Your network is your net worth. You are worth nothing if you are by yourself. That's it.
Awesomely stated. We have a question in the back, please.
Yes, I was just first of all want to compliment the panel. It's a great panel. My name is Winona Hollins-Haig, and this is my first year here. But I just wanted to say I have a disclosure. Both Jim and Betty are colleagues of mine, and Jim and I worked through the ICC, the Intercultural Cancer Caucus, and many of the things that we're doing here, the ICCnetwork.org, actually, I believe, has contributed to the foundation of what we're doing here in this room. I also wanted to say that Betty Thompson, Dr. Betty Thompson, I was one of the recipients of the training she talked to you about, not that specific one, but another core. We actually had an R01 grant. I don't know if it was R01, Betty, but we ended up getting one of your small grants, which led me to a R01 bigger grant with MD Anderson through the ICC. And to make a long story short, I have been involved in 2 major grants that have helped the communities at large. And it's through the work of both of these folks that we see on the panel that we had that opportunity. And last but not least, there is, to your question, there is a National Community Committee, of which I sit on, which is funded by the NIH and the CDC. And there are several institutions, Fred Hutchinson, where I am, and Betty, where we are. I am the past chair of the CAB for that School of Public Health at University of Washington. So in your areas, you may have those NCI-funded NIH National Community Committee. Look it up under NIH. And you can then be a part of your community's work in outreach and advocacy.
Yeah.
Thanks.
Yeah, tremendous. We have a question over here as well. And then also the Scientist to Survivor program. It's not just a program, but there's a cohort that exists. Again, as I mentioned before, this program has been ongoing since 08 to 09, as long as I've been involved. And each year you have this cadre of individuals that come. And how is that network really growing and evolving and being integrated? We just don't want you guys to come and just say we had a great time. Hopefully it creates this interaction that lasts over time and you start seeing the impact of it. Okay.
Hello, my name is Lou Long, I'm a survivor advocate. I want to thank the ACR and Karen, especially the panel up there, and a special thank you to Colonel Williams for his first for his service and for his advocacy. As Colonel Williams addressed, I had 3 sisters, I have 3 daughters, and I've been married for 40 years. We don't know how you guys did, and hopefully we're trying to get men involved with some of this stuff. I don't know, maybe if you have a better insight, how maybe you can talk to your men to get us insight. I'm on a few committees and conferences. I go to a conference, there's 100 people. If there's 10 guys, that's a lot. I have a support group in Philadelphia. I meet every month. We used to call it support group. Now we call it breakfast to just get us to meet. But maybe you women here in this room have some insight as to how to get men engaged. You know, we're tough guys. We don't like to talk about things, touchy-feely things, but prostate cancer, we don't really want to talk about with women. Is there any way, some of certain diseases or any other way, people in this room can figure out a way to get men involved with some of this stuff?
Excellent point. Colonel, do you want to respond or offer some sentiments on
The
that?
people behind you want to.
Oh, okay.
Good morning. I'm Phyllis Massey. I'm an enrolled member of the Oto Missouri Tribe and a member of the Cherokee Nation. And a couple of remarks about the panel. Men getting involved, you hire them. If you're in a position, you hire them. And that's what my program did. I'm at the Huntsman Cancer Institute because you're very right. I try and talk about it, they don't want to listen to me. They will stay silent. The other thing is I was one of the babies here. I really didn't have an experience. I don't have cancer in my family. And I saw a need. And so I started a program with the Huntsman Cancer Institute to fulfill that need. And the people on the panel were my mentors, and many people who come into this room were my mentors. And I am now ending up being a co-chair of this conference next year. So I came with very little knowledge, really no understanding of what the work of advocacy was, but this program built me, and the people who come here built me. The other thing that I think is very important, especially for those who are independents, is Dicey, for example. She changed the future and direction of this program by a small grant that she got and we matched. And you don't know this, Dicey. But that film that you produced, she came with one purpose and ended up with a different purpose and a different project. And what that film did was it highlighted the fact that in your local communities, your physicians and your local clinics, your physicians and your nurses and your clinic staff there have no resources. When it comes really to connecting with a large institution like the Hutch, or Huntsman Cancer Institute because a very poignant remark was made that they put on tape was, I don't see a woman when she comes into my clinic. I see a diabetic. And I've never checked or thought of gynecological cancers. And that was so important. And it stuck with me because we tend to look at people as their diseases. And it's only through our eyes can we find those resources to give to those physicians. We find those physicians and change their perspective. And that's what you learn here.
All right, so we have time for one more question. And our panelists will be around throughout the meeting for you to interact with them as well. We're going to round up this last question.
Okay, so
in the rear there, isn't there a question?
okay.
Yeah, a lot of people have their hands up.
All right, so
It's the
last
hour.
question, but I guess also, just as a quick point, we never really got a full answer for Luce.
Yes.
Oh, you're about to do that? Okay.
Yes. We're going to come back to you.
Hi, I'm Diane from Brooklyn. I'm a cancer survivor, sexual colon cancer. Thank you, panel, for this inspiring morning. To answer your question, I'm going to go outside of the box. My organization is Beat Stage 3, and I did a men's initiative called Cognac and Conversations. So, sorry, I was at a bar. Because I feel like you need to meet the men and the males where they are, where they hang out. We've done a barbershop. We've done Super Bowl. And so I did bait and switch. They thought they were coming for cognac. And you had to stay for at least an hour in order to get your cognac. And within the hour, I had a panel of physicians, male doctors, come and speak to them about the importance of prevention of prostate screening and colon cancer prevention. And we had an amazing time. They found new friends that they didn't think they would have. We shut the bar down, so that night was only men. Women had to bring their men, and then they had to go. They hated me, but it was fine. And we had a really, really good conversation about what they didn't understand, what they're normally embarrassed about asking. And that was one way that I did it. I just stepped outside of what the norm is, like the workshop model. Nobody wants to do that. No one wants to sit through PowerPoints after work. So we had a good time, and they got their cognac. They each got a nice little bottle, and I had it sponsored by Cavassier. So I kind of reached out to something upscale who really, they came out and helped me. I was very surprised, but asked some of those other big name organizations, and it doesn't have to be drinks, obviously, but it was a neighborhood, very well respected area and owned by someone we know. So also reach out to like owners who also sponsor a night where you can shut it down for just you guys.
Oh, that's great. Thank you.
So again, could you please join me in thanking our esteemed panel for the great information that was provided for us this morning. I'm sure that we'll be around throughout the meeting, and wish you well for the rest of the day in terms of engaging not only with science but also with other advocates.